Yeah. So my name is Amonigo Michael Bubu. I am a physician scientist, and my overarching research goal centers on two pillars. That's neurodegenerative and neuropsychiatric diseases prevention and improving the cognitive health of middle-aged to elderly minorities. Specifically, I'm interested in examining social determinants of health vis-a-vis understanding mechanisms that underlie how age-related and age-dependent sleep changes and vascular risk impact cognitive decline and Alzheimer's disease risk. More importantly, um, I'm interested in looking at how they possibly drive Alzheimer's disease disparity. Um, I am affiliated with the Columbia uh, RCMAR Center, and my study and research basically intended to examine the interactive association of obstructive sleep apnea and race on novel plasma biomarkers of Alzheimer's disease uh, neuropathology, specifically plasma tau and neurofilament light protein. So the idea basically was to, you know, recruit about 120 subjects, evenly split between blacks and white. Um, with COVID and all, I had to make certain adjustments. So ultimately, these studies were not necessarily balanced with race as I wanted it, you know. But I ended up looking at just examining the interactive association of obstructive sleep apnea and amyloid burden and the cross-sectional association with plasma biomarkers, of A beta and tau as well as NFL. So the race portion, I was not able to uh, do that aim. And again, this was the reason was basically because of I didn't wasn't able to recruit the proper sample as I wanted them to match with race. But I was able to answer some very, very important and cogent questions. So the rationale really for the project is that we know that obstructive sleep apnea and Alzheimer's disease, right? Very, very prevalent disease conditions in adult and in the elderly. And specifically for the research that I was able to conduct, looking at the association of obstructive sleep apnea severity and novel plasma biomarkers of Alzheimer's disease pathology, now including plasma, A beta, tau, and NFL, um, the background will be, understanding that we know that OSA, that's obstructive sleep apnea, increases AD risk. It is associated with CSF levels of A beta, tau, as well as higher brain uptake of amyloid and tau PET, even in cognitively normal individuals. And we know that recent evidence point to the fact that plasma biomarkers of AD, they have a high potential for diagnostic accuracy for AD prediction. So what we try to do in this study was examine and determine the association between obstructive sleep apnea with levels of plasma A beta 40, plasma A beta 42, plasma A beta 42/40 ratio, tau, and A beta 42 ratio, as well as NFL. Did this independent of amyloid and examining as well with the synergistic effect of amyloid. So basically, what you see for the study really, we did a cross-sectional analysis, right? From baseline data, got the 120 sample that I needed, but again, not balanced well as I wanted with race. So I couldn't really answer the race questions in terms of biomarker differences. Um, but I, these participants were selected from ongoing prospective longitudinal studies utilizing NYU cohort of community dwelling, cognitively normal elderly participants, right? These were participating in studies that were ongoing, sleep and aging studies. So of the 120 participants, 70 of them had baseline CSF-A beta, and that was measured using ELISA. And they were classified as a beta positive or beta negative. We did that using NYU data-driven approach. Clinically relevant thresholds really derived from in-house regression modeling. We defined OSA using AHI 4% levels. And levels of plasma A beta, tau, NFL were determined using CIRAD technology. And when the AHI and biomarker data were skewed, we basically transformed them. All right, this is prior to correlation and regression analysis. Now, of the 120 participants, about 67% of them were women, and the mean age was about 69 years of age, and the mean AHI across all groups was about 14. And for the results, independent of amyloid pathologic change, that's independent of CSF beta levels, OSA severity was associated with higher levels of plasma beta 40, plasma beta 42, and just slightly, showing some level of significance with a beta 42-40 ratio. It was not, so AHI severity was not associated with plasma tau. It was not associated with tau a beta 42 ratio, or cross-sectionally was not associated with NFL. Now, the analysis controlled for demographic factors like age, BMI, ApoE4, and education. But what happened was that when we looked at the association of OSA severity, with its effect dependent of a beta levels, and this time around the beta was used as a continuous variable, because even though we looked at the dichotomy of a beta positive or negative, we still didn't have enough power to be able to determine if there were any significant findings. So a beta was now treated as a continuous variable, and we conducted generalized linear models looking at the synergistic effect of OSA and a beta on plasma tau NFL. And when we did that, we actually saw that there were corresponding increases in plasma levels of tau and tau A beta 42 ratio as well as NFL. Okay, so it became significant. So again, the analysis was not powered for examining racial differences. Neither was it powered for looking at strata-specific OSA A beta positivity, but we did see synergistic effect with OSA and amyloid when we looked at plasma tau and NFL. So in summary, what we see is that in this sample of cognitively normal participants, OSA severity was associated with levels of plasma a beta 40, a beta 42, a beta 240 ratio was not associated with plasma tau and NFL, but there was a synergistic with amyloid effect as AHI severity in combination with amyloid burden. There was this synergistic effect on plasma tau and plasma NFL levels. Going forward, I'm trying to make sure that I can get the sample balance by race, as well as increase the sample size so that I can, do OSA strata-specific effects with A beta, as well as look at the racial differences in these biomarker levels, as the recent data coming out shows that there are biomarker differences, but then ultimately examine the role of social determinants of health, increasing stress levels or inflammation, that are driving this kind of findings. Okay, all right, thank you so much.